Hello, dear students and esteemed learners. Welcome back. Now we are having our courses for the seventh week, and the larger theme for this week is healthcare structure and major health programs in India. Now we are trying to understand the structure of the health system in India because healthcare system is having multiple components, multiple organs, you can say, or constituents, you can say. And often, all those constituents are not contributing in the same way. They are contributing in multiple ways, different ways. And sometimes there is a kind of conflict also in their approaches. And so we have tried to understand the theoretical perspectives also, and some of the theoretical perspective did inform about several attributes of the healthcare system in contemporary world. We are trying to see that in the context of healthcare system in India, and primarily the healthcare structures which have developed in the last 100 years. In the previous lecture, we talked about the contribution made by several expert committees and how those recommendations made by various committees were significant in the specific time and how the health structure incorporated those views. Now, today's lecture is very important in understanding the next possible component that we can talk about here, and that is related to how the healthcare system developed certain mechanisms, certain programs, certain interventions through which the disease control could become successful. Earlier, we have seen the prevalence of occurrence of several epidemics and pandemics, which were causing mass mortalities. So, the disease control mechanism evolved in last 200 years, and along with that, the system of immunization and vaccination also developed, and the system of immunization and vaccination did play a very constructive role in preventing the occurrence of the disease. So when we talk about preventive medicine, then what is it that we are talking about? We are talking about actually the means through which the prevention is actually taking place, and immunization and vaccination is very important. We'll talk about immunization and vaccination in the next lecture, but this lecture will talk about the disease control programs in India, which are often identified as vertical disease control programs. I have covered many disease control programs here in this lecture, some of which are malaria control in India, then National Leprosy Eradication Program, National Tuberculosis Control Program, the Smallpox Eradication Program, Goiter Control Program, and then the Mental Health Program or Kala-Azar Elimination Program, etc. Right. So the purpose here is not to go through all the facts related to these various disease control program only. The facts are integral part of that. But the purpose here is to understand the approaches and how these different types of disease control programs came into existence and how they have strengthened the healthcare system and how these are very instrumental in preventing the occurrence of the disease. So, as a student of sociology, we need to understand the functioning of the system, and not only that, basically, how did the system evolve, right? So, do take into consideration the kind of timeline which would be visible when we will talk about these programs, and also the kind of agencies which would be which are remaining involved with these programs, because that will help you to understand the role of the various agencies also, right? As you might have noted, most of these programs, rather all of these programs are basically the national programs. That means these were launched by the national government, the union government. And so the role of the national government is very important in managing the health and disease scenario at the national level. And there are several other programs which are run by the state government, but at this point of time, we also need to understand that when we were talking about the public health, then we stated categorically that the agency which is important in managing the public health affairs are primarily the local self governments. Then the agencies basically which are responsible for the curative health, that is the hospitals or the primary health centers. We'll talk about these things in one of the lectures. Then the state government is having a kind of say in that. But when we have the national level programs, in this situation, the role of the national government is very important. We will also try to see the policies in some of the lectures, because in India, we had the first health policy very late, basically in 1983. So, after getting independence, we had multiple disease control programs because those were considered necessary for controlling the various communicable disease and of course other diseases also. So let us try to have a understanding or go through the slides. Now, first slide will talk about the efforts to control malaria. Yes, of course, we'll talk about the National Malaria Control Program. But before actually talking about the National Malaria Control Program, I just wanted to make you understand that how these disease control programs actually come into existence. Because don't forget that in the early stages of 20th century, the access to the biomedicine was very limited. The way we are seeing the use of the biomedicine or the allopathic medicine, those were not available at that point of time. So, despite the non existence of many of the medicines which are used these days, some of those diseases were actually managed to keep confined to either certain category of people, or somehow the pace of spread of those diseases were checked, or some kind of public health measures were applied. So there were multiple approaches. So just try to understand some of these. Now, DDT powder was first used in India by the armed forces in 1944 for the control of malaria and other vector-borne diseases. Now, we all are familiar with the DDT powder that is basically used at the household level for killing some of the insecticides or pesticides kind of thing. And those were primarily used by the armed forces in 1944 for the control of malaria and other vector-borne diseases. In 1945, the DDT was made available for civilian use in Bombay to control malaria and and it produced some remarkable results within a very short period of time. So, in 1945, the first civilian home was spread in India. The point here is this, that if we want to control malaria, that means we need to control the environment where the mosquito, which is carrying the vector that causes malaria, that needs to be controlled. And if we want to control that mosquito, then for that basically we need to ensure that the environment is safe, safe for the people, and the environment is not uh, in such a condition that the growth of those mosquitoes will take place there. And so this was an initiative. And then usefulness of the DDT prompted the launch of the National Malaria Control Program in 1953. Now you can understand the difference between 1944 and then 1953. In 1944 or 1945, India was not independent. India became independent in 1947, and then we had the National Malaria Control Program launched by the independent government, that is the central government of India. This National Malaria Control Program was built around three key activities: the insecticidal residual spray with DDT, then monitoring and surveillance of the cases, and then treatment of the patients. So basically, the external environment was taken care of. Malaria related morbidity and mortality in India rapidly brought down within a few years. And encouraged by program success, it was converted into National Malaria Eradication Program in 1958. However, as we know, this malaria eradication program could not become successful because even today we see that the prevalence and spread of malaria is there. But we get to know about the approach through which this malaria control program was basically initiated. Then there is one more important thing here. The malaria control program and other vector-borne diseases, namely Kala Azar, dengue, lymphatic filariasis, Japanese encephalitis, and chikungunya were integrated into the National Vector-Borne Disease Control Program in 2002. So, we will talk about this when we will come to that point of time. Then we need to talk about the next important program, which is National Leprosy Eradication Program. It was launched by Government of India in 1954-55. Multi-drug therapy came into wide use from 1982, and National Leprosy Eradication Program was introduced in 1983. So initially it was a control program, and later on it became a eradication program. I hope you understand the difference. The control program is primarily meant to control the spread of that. And once we have controlled the spread of a particular disease, then only we can proceed towards eradication. Eradication means wiping out that problem, right? Because so that is an advanced stage. So we can see that the leprosy program, initially we had the control program in 54-55, and then in 1983 we initiated the eradication program. The strategy for NLEP was based on controlling the disease through reduction in the quantum of infection in the population and a reduction in infective source, thus breaking the chain of disease transmission. And that is what is very important when we talk about communicable disease. We need to break the chain. India achieved the goal set by the National Health Policy 2002 of elimination of leprosy as a public health problem, defined as less than one case per 10,000 population at the national level in December 2005. So, India made good achievement in that. Then next important program is National Tuberculosis Control Program. We all are familiar with the word tuberculosis. TB is one of the serious disease in India. The National Tuberculosis Control Program was set up in 1962 to control and eliminate TB. So controlling as well as eliminating, but it failed to achieve either goal. Then in 1993, World Health Organization declared tuberculosis to be global health emergency, and the problem was particularly severe in India. The Indian government responded with the revised National Tuberculosis Control Program, which is better known as RNTCP, an initiative to reduce the incidence of TB in the country and to cure TB cases. This RNTCP, which applied the WHO recommended strategy of directly observed treatment short course, generally known as the DOTS program, right? The directly observed treatment short course, DOTS. It was launched in March 1997. The RNTCP was expanded across the country in a phased manner. Full nationwide coverage was achieved in March 2006. So, we can see that when we are having one specific control program, then the approach or the strategy is often changing with time, and that may engage the interval of few decades. So if the disease is not getting controlled, that means the approach needs to be changed, which is quite visible in the case of this National Tuberculosis Control Program. So this is again very important that the mechanisms are actually evolving. Then National Smallpox Eradication Program, we have seen that how smallpox was creating huge problem at global level, and India was also hugely impacted by that. So, the National Smallpox Eradication Program was founded in 1962 with the goal of vaccinating the whole country within 3 years. This is basically related to the vaccination program, and I have covered this topic at length when we will talk about, I'll cover this topic when we will talk about the vaccination and immunization program. But I have placed this particular slide here so that we get to know the timeline that in the 1960s at the national level several programs were started, not only the disease control programs but also the immunization program was simultaneously running, right? So let us move to the next one, that is the National Goiter Control Program. The Government of India launched a 100% centrally assisted National Goiter Control Program in 1962. In August 1992, the National Goiter Control Program was renamed as National Iodine Deficiency Disorder Control Program. That means, although we started in 1962, but the problem was not addressed till then, and that is why the focus had to be changed, the name had to be changed because the problem was persisting. So this program became the Iodine Deficiency Disorder Control Program with a view of wide spectrum of iodine deficiency disorder like mental and physical retardation, deaf, stillbirth, abortions, etc. So actually one important thing here is this, that in the 60s basically we were not even aware of the causation of some of these diseases, especially the mental retardation, etc. So over a period of time we got to know that these problems are caused because of iodine deficiency also, and so this program which was primarily the Goiter Control Program became the Iodine Deficiency Control Program. So this is also helpful in understanding the convergence within the programs basically, right? That a program was started with one specific goal, and over a period of time we got to know about the other related things, and then the other aspect also converged. Then National Program for Control of Blindness and Visual Impairment. This is again a very important program. It was launched in the year 1976 as 100% centrally sponsored scheme, and as of now 60-40 in all states and 90-10 in northeastern states. So you will get an idea here that what do we mean by 100% centrally sponsored scheme, or what do we mean by 60-40 or 90-10. Basically, when a specific program is started, then it needs lots of funds. So when we have a centrally sponsored program, that means the fund is provided by the central government. And when we have a condition like 60-40, that means the central government will provide the 60% of the budget, and the remaining 40% budget will be provided by the state government, which is applicable in most of the cases. And for the northeast states, which are basically smaller, so the 90% of the funding is given by the center and the 10% by the states. So we get an idea about the budget and funding related to these programs also. Then I have added here that what were the main causes of blindness. This is important. You don't need to remember the percentage, but you need to have an idea. So the main causes of blindness were actually cataract, then refractive error, then corneal blindness, then glaucoma, surgical complication, etc. Right? So there are few other names that you can go through. Then we come to this very important program, this National Mental Health Program. Now, National Mental Health Program is very important in the sense that this realization came very late that mental health problems are also very serious problems, and these are actually health issues. Very often, the mental health problems were not even considered the health related problems. The biological aspects related to that, or the medicinal aspects related to that, were not known well. Although we have gone through some of the severe or serious critiques basically of the process of medicalization, but we need to understand that there are evidence based programs, so we cannot apply one particular concept as a blanket concept to dismantle or understand or discard the entire uh, understanding related to that, right? So the point I am trying to make here is this, that mental health issues do need some kind of specific medical intervention. To address the huge burden of mental disorders and shortage of qualified professionals in the field of mental health, Government of India has been implementing the National Mental Health Program since 1982, and the District Mental Health Program was added in the program in 1996. The program was re-strategized in 2003 to include two schemes: modernization of state mental hospital and upgradation of psychiatric wings of medical college and general hospitals. So various approaches are there to handle these kind of problems or these important health issues. But one advantage that we have in this particular lecture is this, that often people say that the government is not taking care of the mental health problems. We can understand that the government had already initiated a national level program to address the problems related to mental health, and this program is again evolving, because if the parameters identified earlier were not working, then the program needs to be re-strategized. Then Kalazar elimination program. Government of India launched a centrally sponsored Kala Azar control program in 1990-1991. The program was intensified during the year 1991, resulting in reduction of morbidity and mortality to 22,625 cases and 277 deaths in 1995, in comparison to peak incidence of 77,102 cases and 1,419 deaths reported during 1992. Then we come to a very important program, that is National AIDS Control Program. We have been talking about this because AIDS and HIV had created great trauma in the 1980s, and some of the important interventions in the health programs got started in the aftermath of this uh, onslaught of HIV/AIDS, right? So let us see what kind of provisions were made in this program very briefly. The National AIDS Control Program, launched in 1992, is being implemented as a comprehensive program for prevention and control of HIV/AIDS in India. Over time, the focus has shifted from raising awareness to behavior change. Now, at the initial stage, there was a focus on raising awareness because it was stated that awareness is the only way of preventing the occurrence of those diseases. But from awareness to behavior change, that means the kind of behavior which is causing the spread of the disease, that needs to be changed, right? So we need to understand this kind of shift in the approach. So from raising awareness to behavior change, and from a national response to a more decentralized response, and to increasing involvement of NGOs and networks of PLHIV. Now, what do we mean here? A decentralized response here means that the problem of HIV/AIDS is scattered. Some of the states are having more problems, and some other states are not having that kind of problem. So the states which have more problem, they need to focus, they need to take care, and they need to develop the mechanism and the approaches through which that can be controlled. So this is basically from national towards decentralization. And then what is this PLHIV? So persons living with HIV, that is the short form of acronym of that. In November 1999, the second National AIDS Control Project was launched with the World Bank credit support of US dollar 191 million. So this program basically run not only from the funding of the government, but also very often we get funds from the global agencies also. Then National Viral Hepatitis Control Program. So we all are familiar with the hepatitis infection, but as of now we are talking about the National Control Program. A national steering committee was formed for development of National Action Plan for Viral Hepatitis in 2017, and the National Viral Hepatitis Control Program was launched in 2018 on the occasion of World Hepatitis Day, which is 28th of July. So these were some of the important disease control programs which have played very important role in controlling the massive spread of these problematic disease. And then these have played very important role in preventing the premature mortalities. In one of the previous lectures, we talked about the life expectancy before independence, as it was suggested by the Borek committee, and that was very low. So if we have achieved the life expectancy at birth of 70 and more, then we have traveled a long path, and definitely the very important disease control programs have played a crucial role in that. So this is all for today's lecture, and here you can see one think about this problem and one activity question. So with that, we come to end of this lecture, and we will meet in the next lecture. Till then, take care.